For those of us who follow health trends, it's a question that, well, it always lingers. Why do some families seem to carry a heavier burden of certain illnesses like cancer than others? It's a profound thought, isn't it? To consider the unseen threads, sort of connecting generations through health.
It truly is. And while cancer is definitely complex, influenced by everything from our environment to lifestyle choices,
Right.
there's a foundational piece of that puzzle that, well, it often gets overlooked. Hereditary cancer syndromes.
And that's exactly our mission today. We're talking about a significant chunk, actually, of all cancers that aren't just random bad luck, but rather have a direct genetic link, a legacy passed down. So this deep dive is designed to be your shortcut, really, to understanding the critical role of these inherited genetic mutations. We'll focus particularly on BRCA1 and BRCA2, but also look at the broader picture of genetic predisposition to cancer.
Yeah, our aim is to distill the most important insights from all the research out there, providing maybe some surprising facts and definitely essential knowledge. We want you to walk away feeling genuinely well-informed on this. It's a vital field.
Okay, so let's unpack this. Let's start with the big picture.
Yeah.
What exactly defines a hereditary cancer syndrome?
Okay. So at its core, a hereditary cancer syndrome is a genetic disorder. It stems from an inherited mutation in one or more specific genes.
Okay.
And this mutation dramatically predisposes individuals to developing cancer. What's really crucial to understand is that these cancers often show up at an early age.
Earlier than usual.
Yes, significantly earlier sometimes. And individuals can even develop multiple independent primary tumors throughout their lives.
Wow. So it's not just you might get cancer. It's a seriously elevated risk, potentially younger, and maybe even in more than one part of the body.
Exactly.
How common are these syndromes overall?
That's a great question. Well, 5 to 10% might sound like a small percentage of all cancers. You have to consider that cancer affects millions globally. So this actually means hundreds of thousands of cancers each year have a direct, identifiable, inheritable cause.
That's a huge number when you think about it that way.
It is, and it means we can often identify this risk and act on it proactively. It's really a profound shift in how we approach prevention and early intervention. Scientists have already identified over 50 distinct forms of these hereditary cancer syndromes.
50 different forms. That's quite a range.
Yeah.
When we talk about the genetic foundation, what kind of genes are we typically looking at?
Well, many of these syndromes stem from mutations in what we call tumor suppressor genes.
Okay, tumor suppressors.
Yeah, think of them as the cell's internal police force, constantly patrolling and correcting errors to stop cells from becoming cancerous.
Makes sense.
But other affected genes can include DNA repair genes, really crucial oncogenes, which are sort of the opposite. They can accelerate cell growth when mutated.
Like hitting the gas pedal.
Exactly. And even genes involved in angiogenesis, which is the process of building new blood vessels that tumors need to grow.
So if these police genes or the repair crew genes are faulty, what happens inside the cell?
Well, a critical point here is that a common outcome is defects in the DNA repair mechanisms. When these repair systems aren't working right, DNA damage just starts to pile up. It accumulates.
Okay.
And this accumulation then leads to errors when DNA copies itself, resulting in more mutations. And eventually, some of those mutations can give rise to cancer. It's like a small crack in a foundation that if you don't fix it, eventually the whole structure is compromised.
That's a really clear analogy.
Yeah.
Okay, so how do these faulty genes actually get passed down? I know there are different ways inheritance works.
Indeed. The most common pattern we see for these cancer syndromes is called autosomal dominant inheritance.
Autosomal dominant.
Okay, this just means a person only needs to inherit one faulty copy of the gene, what we call an allele, from either parent to be at that increased risk.
So even if one parent has a normal copy and the other has the faulty one, if you get that faulty one, you're predisposed. You have one of each, sort of heterozygous.
Precisely. You've got it. And in this autosomal dominant situation, if one parent carries the mutation, each child has a 50% chance of inheriting it.
50-50.
Yeah, it's literally a coin toss with every single pregnancy. This fits nicely with something called Knudsen's two-hit hypothesis.
Oh, I've heard of that.
Right. The idea is the first hit is that mutation you inherit at birth. The second hit is another mutation that happens later in life in a cell.
Ah, okay.
And because you start life with that first hit already, your odds of getting that second hit and developing cancer are much higher than someone starting with two good copies.
That really clarifies it. What about the other pattern, the autosomal recessive one?
Right. That's less common for cancer syndromes, but it happens. Autosomal recessive, in these cases, both copies, both alleles of a gene must be mutated for someone to have that predisposition.
Both copies need to be faulty.
Correct. So if both parents are carriers, meaning they each have one mutated allele and one normal one, they're heterozygous carriers, then they have a 25% chance, 1 in 4, of having a child who inherits 2 faulty copies and thus has the predisposition.
Okay, 1 in 4 in that case. Could you give us a couple of examples for each pattern just to illustrate the diversity here?
Absolutely. For autosomal dominant, some well-known examples are familial adenomatous polyposis, or FAP, that greatly increases colorectal cancer risk.
Okay.
Then there's Lynch syndrome, another major cause of hereditary colorectal cancer and also uterine cancer in others. And Li-Fraumeni syndrome, which is quite rare, but predisposes people to a whole range of cancers, often at young ages.
Wow. And for the recessive ones?
Good examples there include Fanconi anemia, which involves not just early cancer risks, but also bone marrow failure, and xeroderma pigmentosum, where people have extreme sensitivity to UV light and a massive risk of skin cancers.
It really shows how varied these conditions can be. All right, let's zoom in now on probably the most recognized genes in this whole area, BRCA1 and BRCA2. What exactly are they and why are they so important?
Right. BRCA1 and BRCA2, they stand for breast cancer genes 1 and 2. They are incredibly important tumor suppressor genes.
The police force again?
Exactly. Their main job is to produce proteins that are involved in repairing damaged DNA. They help maintain the stability of our genetic material, our genome. Think of them as, the cell's master repair crew.
So if that master repair crew isn't working properly, maybe they've gone on permanent vacation. What happens then?
Hey, good analogy. Yeah, when these genes are mutated, their ability to repair DNA is severely hampered. It's impaired.
Okay.
This leads to that accumulation of genetic errors we talked about within the cells, which, as we know, significantly bumps up the risk of cancer developing. It's a direct route to genomic instability.
And when we talk about increased risk, what are the actual numbers looking like for BRCA mutations? I know they're quite substantial for breast and ovarian cancer especially.
They are indeed quite significant. For someone with a harmful BRCA1 mutation, the lifetime risk of developing breast cancer is estimated to be somewhere around 55 to 72%.
Wow, that high.
Yes. And for ovarian cancer, it's about 39 to 44%.
Okay. And for BRCA2, is it similar?
Similar, but slightly different ranges. With a BRCA2 mutation, the breast cancer risk is estimated around 45 to 69%.
Still very high.
Very high. And the ovarian cancer risk is about 11 to 17%. Now, while breast and ovarian are the most prominent, it's really important to remember BRCA mutations also increase the risk for other cancers.
Like what?
Things like prostate cancer, particularly more aggressive forms, pancreatic cancer, and also male breast cancer.
Male breast cancer, right. And just to confirm, how are these specific BRCA mutations passed down? Is it that same autosomal dominant pattern?
Yes, exactly. BRCA mutations follow that autosomal dominant inheritance pattern.
Okay.
Which means, again, if a parent has a BRCA mutation, each of their children's son or daughter has a 50% chance of inheriting that same mutation.
So it's really not just women who can carry these or pass them on?
Absolutely not. That's a critical point. Both men and women can carry BRCA mutations and pass them on to their children, even though the main cancers we associate with them, like breast and ovarian, are obviously much more common or visible in women. It's vital for understanding family risk.
This leads us perfectly into genetic testing.
Yeah.
Given these kinds of risks, who should be thinking about getting tested for BRCA1 and BRCA2 mutations?
Right. Genetic testing for BRCA1 and 2 isn't for everyone, but it's typically recommended for individuals who meet certain criteria that suggest a higher likelihood of carrying a mutation.
What sort of criteria are we talking about?
Well, things like a personal history of breast cancer diagnosed before age 50, or a family history with multiple relatives, perhaps across different generations, who've had breast, ovarian, pancreatic, or prostate cancer, especially if those cancers occurred at young ages.
And I remember reading that a male relative with breast cancer is also a pretty strong indicator.
That's right. Male breast cancer in the family is a significant red flag. Ancestry also plays a role.
How so?
Specifically, individuals of Ashkenazi Jewish descent have a much higher carrier rate. It's about 1 in 40 compared to roughly 1 in 400 in the general U.S. population.
Wow, 10 times higher.
Exactly. So that's a key factor. Also, a personal history of ovarian cancer at any age, or having breast cancer in both breasts, bilateral breast cancer, would definitely warrant a discussion about testing.
Okay, so if someone fits these criteria and decides, yes, I want to get tested, what does that process actually involve?
The first step, and arguably one of the most important, is genetic counseling.
Right, the counseling.
Yes. This is a session, or sometimes multiple sessions, with a trained genetic counselor. They help you understand the pros and cons, the limitations, the potential implications, emotional, medical, for your family. It's really about making an informed choice and being prepared for whatever the result might be.
That sounds crucial. And the test itself, is it complicated?
The actual test is usually the simplest part, physically. It's typically just a straightforward blood draw or sometimes a saliva sample.
Okay.
That sample is then sent off to a specialized lab that does the genetic analysis.
And then you get the results back. How do you make sense of them? I've heard about different kinds of results like this VUS thing.
Right. So a positive result means they found a pathogenic mutation, a known harmful change in BRCA1 or BRCA2. This clearly indicates an increased cancer risk.
Positive means increased risk.
Yes. A negative result means no known harmful mutation was detected in the genes tested. Now, this is reassuring, but it doesn't mean zero risk. Other factors, or maybe even undiscovered mutations, could still play a role.
Got it. Not a clean bill of health necessarily.
Exactly. And then there's the variant of uncertain significance, or VUS.
VUS.
Right. This means they found a genetic change, a variant, but science doesn't yet know for sure if it increases cancer risk or not. It's ambiguous. These can be quite confusing and sometimes require follow-up as more research emerges.
That sounds like it could be stressful, that uncertainty.
It definitely can be, which again highlights the importance of ongoing counseling.
And just practically speaking, what about cost and those tests you can just buy online?
Testing costs can vary quite a bit, typically ranging from maybe $100 up to a couple thousand, depending on the specific panel and insurance coverage.
Right.
And yes, direct-to-consumer tests are available. However, most experts strongly recommend going through a healthcare provider and genetic counselor.
Why is that?
Well, they ensure you're getting the right test, that you fully understand the implications before you test, and critically, that you have professional help interpreting those results, especially if it's a VUS or even a positive result. It's complex information with potentially big consequences.
That makes a lot of sense.
Yeah.
Okay, so let's say someone gets a positive result for a BRCA mutation. This is where that knowledge becomes power, right? What are the management options they can then explore?
Exactly. This is where proactive management really kicks in. One major pillar is enhanced surveillance.
More screening.
Yes, earlier and more frequent screening tests designed to catch any potential cancer at the earliest, most treatable stage. For breast cancer risk, this might mean starting annual breast MRIs as early as age 25, often alternating with annual mammograms.
Okay, starting quite young.
Yes. For ovarian cancer, the screening tools like pelvic ultrasounds and CA-125 blood tests are unfortunately less effective at early detection, but they are still used as part of the monitoring strategy.
Are there medications? You hear about drugs to lower risk.
Yeah.
What's that called again?
Yes, that's chemoprevention. Using specific medications to lower the risk of developing cancer in the first place, or sometimes preventing recurrence. For breast cancer, drugs like tamoxifen or raloxifene can significantly reduce risk in certain carriers.
Okay. And what about more drastic steps like surgery?
Risk-reducing surgery is a very significant but also highly effective option that many carriers consider. For breast cancer, a prophylactic mastectomy removing the healthy breast tissue can lower the risk of developing breast cancer by an incredible 90 to 95%.
90 to 95% reduction. That's huge.
It is. And for ovarian cancer, having a prophylactic salpingo-oophorectomy, which is removing the ovaries and fallopian tubes, typically after childbearing is complete, reduces ovarian cancer risk by about 80 to 90%.
Wow.
And as a side benefit, for women who haven't gone through menopause, removing the ovaries also significantly lowers their breast cancer risk as well.
So multiple benefits there. Beyond these big medical interventions, what about lifestyle? Does that still matter?
Absolutely. The general healthy lifestyle advice we all hear becomes even more important for carriers. Things like regular exercise, maintaining a healthy weight, eating a balanced diet rich in fruits and vegetables, not smoking.
The usual suspects.
The usual suspects, exactly. And also sun safety, as some syndromes increase skin cancer risk too. These choices definitely play a role in overall health and potentially in modifying that inherited risk, though maybe to a lesser degree than surgery or chemoprevention for the main BRCA-related cancers.
I also seem to remember reading something specific about aspirin for men with BRCA mutations.
Yes, that's relatively recent research. Some studies suggest that regular aspirin use might lower the risk of prostate cancer, specifically in male BRCA
I'm
carriers.
interested.
But the key word there is regular. It seems it needs to be taken consistently, often daily, for at least 5 years or more to show a potential benefit. Obviously, something to discuss carefully with a doctor due to aspirin's own side effects.
Right. Always consult your doctor.
Yeah.
You mentioned earlier the emotional side of getting a positive result. It must just be a tremendous weight, not just for the person, but for their whole family. Thinking about kids, how do genetic counselors really help people navigate all that? The fear, the guilt, maybe?
It's a profound challenge, absolutely. Receiving that positive result can trigger a whole range of emotions: anxiety about the future, fear of cancer, guilt about potentially passing it on, sadness, anger. It's complex.
I can only imagine.
And this is where genetic counselors are invaluable. They provide not just information, but crucial psychosocial support. They help individuals and families process the news, understand their options without pressure, navigate those incredibly difficult decisions about surveillance, surgery, prevention.
And talking to family members, too.
Yes, helping them think through how and when to communicate this information within the family structure. It often impacts siblings, parents, children. Counselors really act as guides through a very personal and often challenging journey.
Yeah. On a more public stage, I definitely remember when Angelina Jolie shared her story about her BRCA mutation and preventive surgeries. That seemed to have a huge impact.
It really did. Her decision to go public brought enormous global attention to BRCA mutations and the concept of risk-reducing surgery. It undoubtedly empowered countless individuals to learn about their own family history, seek testing if appropriate, and feel less alone in making proactive health choices. It destigmatized it to some extent.
Absolutely. Shifting back to the science, what's happening on the research front? How is the field continuing to evolve? Are there new treatments?
Oh, it's a very active area. One of the most significant breakthroughs in recent years has been the development and use of PRP inhibitors.
PRP inhibitors, okay.
These are a type of targeted cancer therapy. Olaparib is a common example. They work by cleverly exploiting the very weakness caused by the BRCA mutation.
How so?
Well, BRCA-mutated cancer cells are already bad at one type of DNA repair. PRP inhibitors block another DNA repair pathway, so when you block that second pathway in cells that already have a faulty BRCA pathway.
The cell can't repair its DNA at all.
Exactly. It leads to so much DNA damage that the cancer cell basically self-destructs. It's called synthetic lethality, and the beauty is it tends to affect the cancer cells much more than healthy cells, which still have working BRCA genes.
That's brilliant. Turning the genetic defect into the target. What else is on the horizon? What's next in research?
Researchers are looking at lots of things. One area is polygenic risk scores.
Polygenic, meaning many genes.
Right. Instead of just looking at one major gene like BRCA1, these scores combine the small effects of many common genetic variants across the genome to get a more nuanced picture of someone's overall inherited risk.
A broader view.
A broader view, exactly. There's also a lot more work being done on gene-environment interactions, trying to understand precisely how our inherited genes interact with our lifestyle, our diet, environmental exposures, to influence who ultimately develops cancer. The goal is even more personalized prevention advice down the line.
This has been incredibly illuminating. It really drives home how understanding our genetic predispositions, especially with genes like BRCA1 and BRCA2, has just fundamentally changed the game for cancer prevention and personalized medicine.
It really has. And while, getting that positive genetic test result can absolutely be life-altering and bring challenges, it also offers this profound opportunity, an opportunity for proactive steps, for earlier detection, and ultimately for interventions that can genuinely save lives.
Yeah.
Knowledge in this context really is empowering.
So as we wrap up, thinking about how genetic testing is becoming more common, more accessible, maybe even integrated into routine care someday, what does this really mean for us as individuals and for future generations as we gain these deeper insights into our own genetic blueprints? How will this knowledge keep shaping our power to make informed decisions for our own health, for the health of those who come after us? It's a pretty powerful thought to end on, isn't it?